Well, good afternoon, everybody. Let me share screen and get going. Can everybody see my slides?
Yes, we just need presentation mode. Let's see.
Is that better?
Perfect. Yep.
Okay. Well, good afternoon again. We are moving apace. I think that's terrific. B9 is one of the forms that had a not insignificant number of changes, so I imagine there might be some more discussion here. I'll just walk through a couple of general oversight and principles, the overview of the form. I'll go into the individual parts of the form, and then I'll open it up for questions. Very similar to what other presenters have done. So the main point is to remember the purpose of B9, which is to flesh out the current phenotype. And the key point that we ask you to do in all instances is to apply your best clinical judgment and to use all available sources to apply the judgment. So you're not actually using this form for direct administration to a participant or a co-participant. You're just being asked to rate whether symptoms are present and to make your best estimate as to when the symptoms begin. So you, the clinician in this instance, is functioning as the aggregator of all the data and making decisions about the presence or absence of very specific components of the phenotype that we're looking for. So a couple principles. We're looking to focus on change. We're not looking to record lifelong impairments or difficulties or challenges. And we want the change to be meaningful. And different aspects of phenotype have different definitions of that. For all the phenotype elements, you will be getting some definitions or descriptions. And so we certainly want the clinical judgments you make about presence or absence to be consistent with that. We're comparing to a prior stable baseline. That concept sometimes generates some discussion about what that means. Again, your clinical judgment for us should be paramount. And we ask you to make your best judgment with age of onset. You'll see that we're asking for age of onset for cluster symptoms, say cognitive or behavioral, not for individual symptoms necessarily. So that becomes a little bit harder to do. And in one instance, we're asking you to weigh information across different domains to decide if there's a predominant presentation. And hopefully this will become more evident as I go through this. So there are 5 sections. I'll go through each of them. One is an overview for broad changes across domains. The second relates to elements of cognitive impairment. The third is neuropsychiatric symptoms and behavioral changes. Then motor changes. Then the overall course of decline and predominant domain. And hopefully these will become clear as we look at the form. So changes across domains. So this is a summary form that's asking you as a clinician, either as hearing what's reported by the participant or reported by the co-participant, to decide whether there's a decline in any cognitive domain, in any motor domain, or in the neuropsychiatric space. And you can rate a no or a yes for each one of these, or a could not assess. These are mutually exclusive, obviously. And these are about what the participant tells you. This is what the co-participant tells you. If there's no co-participant, you can rate an 8 here. And similarly, do you hear from the co-participant reports of a cognitive decline, motor change, or significant neuropsychiatric symptomatology? And then finally, as a clinician, we ask you to decide whether any of these domains are affected. And so if all of this is negative, then you will end the form here and move on to the next form. With regard to cognitive impairment, we want to see if the participant is meaningfully impaired relative to the stable baseline that we refer to. In your judgment, is the participant currently experiencing meaningful impairment in cognition? Yes or no? A no skips out. If there is meaningful impairment in cognition or there's fluctuating cognition, we ask you to rate whether any one of these following domains are affected: memory, orientation, executive function on this page. So here you're given definitions or descriptions of the kinds of changes that we would refer to for a memory change and so forth. And then other domains of cognition are also rated here: language, visuospatial, attention concentration, whether cognition is fluctuating. And there's room also to specify cognitive change that you think should be recorded, but that is not fit one of the previous groups. We also ask you to decide the age. So this is the point I was making before. We're asking you to look for the earliest symptom in aggregate of the symptoms that you rated before. So once you've rated what symptoms you think are present, you'll then go back and think about which was the earliest age of onset and put down in your best judgment what that was. And we also ask you to make a judgment about the mode of onset of cognitive impairment, going back to something we've all been taught for years. We're interested in whether it's gradual, subacute, or abrupt. Moving to neuropsychiatric symptoms and behavioral changes, many of the changes in B9 are in this space. Our focus here is the last month. We're looking for clinically meaningful neuropsychiatric symptoms or change in behavior relative to a stable baseline. And clinically meaningful change refers to symptoms or changes that are evident most days in a given 4-week period, trying to come up with a threshold so that day-to-day fluctuations in mood, for example, that happen rarely would not be rated as the symptom. So first, based on your overall judgment, is there such change? If the answer is no, you skip out. Otherwise, you are then asked to rate changes in the last month, yes or no, and we give you guidance. This guidance, you will notice, is very similar to the elements that come from the NPI or the GDS, and we're doing that on purpose. We want to be consistent across forms and across centers with what we mean when we talk about apathy or depressed mood and so on and so forth. So again, for these mood, motivation, and agitation areas, we ask you to rate presence or absence in the last month representing clinically meaningful change, and then we're asking you for an age of onset. This pattern repeats itself when we ask you to rate presence of psychosis or impulse control. For visual and auditory hallucinations, we get a little bit more detail about whether specific types of hallucinations or hallucinations are present. A reminder, visual hallucinations, participant exhibits visual perceptions without a stimulus. Same idea here for auditory. And we have a definition of delusions if the participant has fixed idiosyncratic beliefs that are not true, with a few examples. Aggression is a little bit easier. And so for all of these, again, we're asking you to give us your best estimate as to the earliest age of onset for one or more in this space. Personality changes are rated here. Again, these are terms you've heard before. We're giving you definitions for the sake of consistency. We're looking for disinhibition, personality change, loss of empathy, obsessions, compulsions, explosive anger, and so forth. And we also have added here the issue of excessive substance use and the kinds of substances that are used. We're putting these into personality, even though arguably they would fit in a section of their own, but we've decided to do it this way for the sake of simplicity. And again, we're asking you for an age of onset for these. Other changes, we're looking for evidence of REM sleep behavior disorder. You have the definitions or the guidance that we have here. And for all behavior changes, we're asking for the most prominent behavior problem and thinking about whether the onset and progression is gradual, subacute, or abrupt. The pattern now repeats itself with regard to motor changes. Again, we're looking for meaningful change in motor function relative to stable baseline. There's the standard skip out question, and then we ask whether you see meaningful change in motor function. You can use all sorts of information to make the judgment. We give you guidance and definitions. We're looking for changes in gait disorder, fall, slowness, tremors, limb weakness, changes in facial expression or speech. And then we again ask you for the best judgment you can make about the earliest age of onset. We are looking for the mode of onset. As we did before, we want a specific poll as to whether you think there is evidence of motor function suggestive of Parkinsonism, so that we're trying to move away from rating what you see to rating whether you think a particular etiology is implicated by what you see. And the same, again, with some motor function changes suggestive of ALS. Final section, really 2 questions. We're trying to get for the overall syndrome, which considers cognitive, behavioral, motor aspects of change. We want you to rate it in one of these areas as best as you can as well. And we're wanting you also to tell us which is the predominant domain that was first recognized as change. So what did this look like when it started? And we give you the options for this as well. So I'll summarize my points again. The purpose of B9 is to flesh out the current clinical phenotypes. We ask you to apply your best clinical judgment using all available sources. There are the exceptions at the beginning where you're asked to make judgments about cognitive change based on what the participant or the co-participant told you. We are asking this to be filled out with a clinician, and we want a rating of are symptoms present and when did they begin. And just a reminder of the principles, we're focusing on meaningful change. We ask you to be consistent with the definitions provided. We want you to compare to prior stable baselines and use best judgment for estimating age of onset or to make calls across domains, for example, as to which domain you think is most predominantly affected. And with that, I will end it. You can connect with me if you have any questions about B9, and certainly you can have another look at this webinar if that would help you clarify things. And I will stop sharing and look for questions.
Just a question about B9 and the timing of which symptoms came on first. So it's meant to be captured under each section. There's a section that says age of onset, approximate age of onset of cognitive impairment or age of onset of the psychosis, behavioral changes, etc. So that's meant to try to get at what features came on first. We thought about doing that for every single symptom, but thought that would be just too much. So,
and let me sort of point out that this section 5 at the end indicates the predominant domain that was first recognized. So I think this is where we're trying to capture the initial clinical presentation. So to John's question, you are not missing anything. We simply have somewhat changed how we're doing this. So we're asking you at the end of the form to tell us what was the predominant presentation at the beginning, but not necessarily the predominant symptom. Correct? It doesn't say specifically what symptom is first. We've had to make judgment calls. There are lots of important information that we understand we're not going to be collecting. But our sense was that in the interest of not excessively burdening participants and clinicians, it made sense to take this approach.
and if people are followed longitudinally, you'll note whether they had the symptom at one point